I can't think of anything really more exciting than what we're doing right now with imaging, and we've come a long way. And I've had the pleasure of talking about PYL, also known as PYLARIFY, which was just FDA approved, and the report on a couple of really good studies that were done by investigators in this arena. So my learning objectives are pretty straightforward. I want to define biochemical failure because that's what I'm going to focus on where this is used. We're going to look at the radar guidelines, radar 1 and 3, and why radar 3 are important. We're going to talk about next generation imaging and a subset of men with biochemical failure, and then focus on a couple of important trials, or two of them, with PYL, Osprey, and Condor. My presentation is going to focus mainly on Condor. And then some new terminology we're going to throw around, SOT and CRL, and I'll tell you what those are in a minute. Okay, two publications, one in the Journal of Urology. This is the Osprey trial. Again, I'm not going to go into this. This sort of bookends what I'm going to talk about, biochemical failure. So Osprey deals basically with men with high-risk localized disease and imaging. With this agent, we all know that there are a group of men that have PSAs of 60, Gleason scores of 8, and we know darn well they have disease somewhere and the imaging is negative. And this was something that was brought out in our radar trials, and I'll show you that in a minute. The second study is the one I'm going to talk about, is Condor, and that was just published and disapproved by the FDA. And this study focuses on men with biochemical failure in imaging. All right, this is a 30,000-foot view of the Condor study, but basically this is looks at PYL, also now known as PYLARIFY, and it is looking at management of men who have had biochemical failure and non-informative, and that's the word, local imaging, get the imaging, and then look at outcomes and ability to identify the lesions, and does it change practice. And something unique here, at least in this study, there were 3 blinded readers, and then we had 2 standard of truth panel members who looked at are we really telling the truth here, and I'll go through that in a minute. All right, biochemical failure. At this meeting, probably 20-some years ago, Paul Lang reported that there is this test called PSA that identifies men who fail local therapies, particularly radical prostatectomy. And I remember him doing that really almost 3 decades ago. And what happened was this created a monster, in an effect, a disease state, a iatrogenic disease state called biochemical failure, where we would institute lots of different therapies, including hormone therapy, radiation, salvage therapy after failing radiation, and so forth. We know that, and it's hard to admit, that anywhere from a fourth to half of the men that we treat will fail their primary therapy, and we call this biochemical failure. We know that that stimulates anxiety, and we've all heard this sort of cliche that PSA stands for patient-stimulated anxiety, and that led to us using a lot of therapies, including androgen deprivation therapy, and creation of non-metastatic castrate-resistant disease as a new disease state. We also know that the failure rate, the cutoff for radical prostatectomy is probably 0.2. There may be some exceptions, local tissue left behind, whatever. By radiation, it is 2 nanograms per ml above a nadir. We had a nice review of that done by Dr. Carroll. We also I'm going to talk about conventional image. Doesn't give us a very good answer in most of these patients in the radar 3 guidelines. The radar guidelines, the first one was convened, it's hard to believe now, and 2019 we reported it, and then radar 3 also. But radar 1 was basically, we were over imaging people with localized disease, and when did you do it in biochemical recurrent patients. Radar 3 focused on a number of things, but one of the things that came out was that next generation imaging probably was indicated in men who had biochemical failure and PSAs above 0.5, but conventional imaging was not so good in these low PSA levels. So let's dive down into the Condor study and the design and the objectives. This was a really great study that looked at the utility, the clinical utility study of PYLARIFY PET-CT in patients with biochemical recurrence of prostate cancer, and they had non-informative standard of care imaging. So the key components of this was central imaging, blinded independent reviewers, and 2 truth panel readers, and we'll talk about that. 208 men were accrued. The primary endpoint was pretty straightforward, and it was some new terminology that we introduced a lot of new terminology in prostate cancer and in imaging recently, but it's called correct localization rate. And that means that there is a 1-to-1 correlation between where the lesion is on the imaging and where it is when it was found by standard of truth. You know, that's the most important correlation would be histology, but other things would be secondary imaging and things like that, or PSA failures and changes. Secondary endpoint was a change in how you manage the patient, and I think that's very important, that you can have all these tests, but do these tests, in fact, are they actionable? Are we going to do something different? And so the patient population was rising PSA after definitive therapy with negative or equivocal conventional imaging. So whatever your imaging was it bone scan, was it CT scan? Some people had other PET imaging and things that they did. The definition of failure was what I just mentioned, 0.2 after radical prostatectomy, and a rise above 2 nadir if it happened to be cryotherapy, brachytherapy, or some of the other local therapies. Patients who were on ADT concurrently or other systemic therapies were excluded. So here is an outline of the baseline characteristics, and median age was 68, and 50% were radical prostatectomy failures, 15% radiation, a third of them were radiation and radical prostatectomy, and there was some that had systemic therapy that was one. The median PSA, which was very important here in this study, was 0.8, and I think we have to remember that. If we group PSAs like 0 to 2, what we see is that 66% were in that range. And if we go to the one that's sort of dicey, is less than 0.5, what we see is that 34% were there, and 0.5 to 1 was about 17%. So 52% of patients with negative whole body scans were in this. 9% presented with, and as I mentioned, people could have other scans, negative flucyclovine or choline PET scans. So the standard of truth, this is an interesting concept, and basically there are 3 levels to this about how much you're telling the truth, so to speak. So they underwent assessments by the local player after the local results for evaluation and comparison to whether histological findings like biopsies, whether informative things like further conventional imaging, like other imaging things like oxygen, flucyclovine, choline PET, MRI, whatever, or probably the weakest one was the patient got treated and the PSA responded and went down. So we have defining terms of diagnostic performance, and basically we're all pretty familiar with sensitivity, specificity, positive predictive value, and negative predictive value. And we also have this new thing that we add. It's called correct localization rate, which is CLR, and that's the percentage of patients with 1-to-1 correlation between at least one lesion identified by a given diagnostic modality, standard of truth, and the imaging. And I'll go into that in a minute or two. So here is an example of correct localization rates. And again, correct localization rates at the patient level is percentage of patients with a one-to-one correspondence between lesion level localization and greater than one lesion in PYL imaging and standard of truth. So if the PYL central reader said there was a left pelvic bone lesion, but the standard of truth was another way to determine it was on the opposite side, a biopsy, MRI, or something like that, this was a false positive, and the CLR rate was 0%. If it said it was the right common iliac node, proved it, true positive, it was 100%. So this was the correlation. Now, if you looked at the PYLARIFY PET CT and prostate cancer biochemical recurrence and the CRL rates, we have, as I mentioned, 3 readers. So how do the readers compare to each other? And so there are a number of things that they could have said, like negative PYL scan on the subject level, positive PYL scan, PYLARIFY scan, and also we have the correct localization rate. And so what we see when we look at reader 1 with our 208 patients, reader 2 and reader 3 was there was almost, nothing's perfect correlation on the negative side in the 40% range down to 34%. On the positive side, 65, 59, and 59. That's pretty good. On the correct localization rate, again, pretty good, 85, 87, and 84. And I point out that the FDA set the bar at 20% because that's what was seen in some of the prior studies. So anything above 20% was considered good. And so the correct localization rate and the standard of truth, again, I mentioned what that is to prove it that what was said found on the scan was actually reflected in the patient. And we looked at that again with the range with the readers, the 3 readers, and with the correct localization rate, the positive predictive value, pretty good, 78 to 82% for CLR, positive predictive value 92 to 93, correlative imaging about 85% each way with CLR and PBV. And the PSA response, that was only one patient, it was 100%. So of the ways that we determined the standard of truth, 31 of these 200 patients or so were histopathology, correlative imaging, so other imaging was about 100, and PSA response was only 1. So then we have, okay, how do the readers work together? And there's something called Cohens capita analysis, and I don't have time to explain it. And if I did, I'm not sure I could. But anyway, basically what it did was look at how the readers compared to each other in the various categories between central readers and local readers, between central reader 2 and local reader, between central reader 3 and local reader, and so forth. And what we have is a kappa score that's pretty consistent of 0.65, and I'm told that that is a very good result. All right, so taking this on home, what we want to look at positive predictive value by anatomic region, and we'll do that. And if we look by reader 1, reader 2, and reader 3, whether it be the anatomic region of the prostate, the pelvic lymph nodes, or the extrapelvic lymph nodes, what was seen by anatomic region was an excellent correlation between the readers. And if we looked at extrapelvic lesions, what we see here again is whether it be lymph nodes, bones, or whatever, and the positive predictive value at this point for extrapelvic lesions was also good, and for visceral and soft tissues. So in general, we can say the positive predictive value is consistent among regions and among readers. So, if we look at detection rates and correct localization rates, so that's CLR by PSA levels, and here's where the rubber meets the road: is can this imaging modality help us in patients who have lesser disease reflected by a lower PSA? And the answer is on this slide, and basically it does give us a good chance by, if we look at the very readers, the 3 readers, picking up the disease earlier. And as oncologists, we all know that there's this thing called cancer is a collection of genetic changes. The longer it's around, the more genetic heterogeneity that exists and the less responsive it is to therapy. And that's why screening, we find it earlier, and we have later disease, we have more mutations and whatever. And so the idea here is, again, if you get something earlier, do you have a better chance? Is it actionable? And I think we have a number of studies that would suggest about adjuvant hormone therapy and radiation and targeted therapy that these things do work. There are comparisons between bone scans and the number of lesions detected. Sodium fluoride PET was felt to be a step forward. One of the problems, and we were involved with some of the early work with that too, is with Dr. Koo, is that sodium fluoride PET seemed to be good, but there were patients who had false positives and missing. And then now we have the FPYL PET PYLARIFY scan, and what we can see compared to other things we have is an improvement. Change in management, that's important. So when you spend the money and the time and the effort to do a test like this, can you find the right people? And then if you find the right people, are you going to alter your treatments over what the standard of care is, the standard of evaluation, like CT and technetium, bone scans, and things like that? And the answer is on this slide, and that is 2/3 of the people, 64% of the evaluable people, had a change in their intended management by using this test. And if we look at this, which way did it go? 79% of the changes were after a positive PYLARIFY PET, and 21% of the changes were after a negative one. So both positive and negative had an effect. Another way to look at that, the treatment plan shifts. And these are important things to talk to patients about, to talk to third-party payers about, and to improve outcomes, is that, yes, there was a shift. We had patients being considered for salvage local therapy, radiation, hormone therapy, or what. 28% of those shifted to a systemic therapy based on this, so the local probably didn't work. And then there were people that were thought to be candidates for systemic therapy, long-term hormonal therapy, spot radiation, whatever. 21% of those shifted over to salvage local therapy. And then we can look at another way to look at it is therapy, observation, and observation to therapy. So there was a shuffling effect that did occur with patients in this study. And so, again, what we see is there was a shift from observation to therapy, and there were people that were getting therapy that were considered for therapy that went for observation, although a small number, 5%. All right, side effects. Basically, and I don't want to downplay those, but you can see that they're all 1% range. The highest is 1.9%, and that was a headache in 4 people. And fatigue, things like that, 1%. There was in some people a taste dysphagia that occurred, and that was in 2% of people. So what are my conclusions? The summary, the efficacy, and safety. The Condor study clearly achieved its primary goal. It went above the 20% bar that was set by the FDA. And so 80 to 87% of CRL was reported by 3 blinded independent central readers. 64% of evaluable patients had a change in intended management, so that's an actionable event. 78% were attributed to the test. Another important thing when you look at economics and you look at outcome and so forth. Side effects were minimal, and there were no grade 3 to 5 outcome changes. So finished with 22 seconds left, and thank you all very much.